Digital technology has largely influenced dental treatment, disease management, and of course, educational delivery. So day-to-day, clinical practice will benefit enormously from fully integrated digital systems. So this all includes, for example, digital radiography with CBCT technology. It includes optical scanning and CAD/CAM manufacturing prosthetic restorations. And of course, last but not least, digital implant planning. And of course, the final drill guide. If we only look at CAD/CAM manufacturing, you can definitely see that it has revolutionized the way prosthetic restorations are produced in a dental laboratory. So digital technology does have a big influence on our profession today, and probably it will be one of the most important technologies in the future. Digital technology, some people are quite conservative, and some people believe that we do not really need digital technology in every indication. And I personally believe that it is pretty important to have these people around. If you only think about a drill guide, there are surgeons who are very experienced who say, we don't need a drill guide to place an implant properly. And I'm an oral surgeon myself, and this is very true. Some people at Team Stony Brook even made a kind of profession out of this. They developed the eye guide. I know, I can say and I can do with my eyes. So it is Vince Iacono who's doing that, and of course he knows what he's doing, so he's very professional about that. But having a drill guide is not really about only placing implants. Having a drill guide is building a very strong relationship to your prosthodontic referral. He will love you for using that tool because he knows exactly that you transfer his planning to the mouth of the patient. At the same time, using a drill guide helps you to open up new avenues in treatment. So placing 6 implants and placing a superstructure immediately after surgery takes you 1 hour, 20 minutes. How can you do that without guided surgery? You use it as a tool, and that is a magic word. You have to compare it to an app on the iPhone. Of course you can use an iPhone or BlackBerry to do calls, but the really great thing about an iPhone are all of these apps, which give you completely different access to new, like navigation system or whatever what you want to use. And the drill guide opens up new avenues for new clinical treatment, which you would not be able to do without the drill guide. And that's the benefit of digital technology here. And there is a very nice definition by the owners of the E4D company, and they just said a lab, a dental lab in the older days is a place that a dentist sent his or her patients and presents to be processed into restorations. Today, a dental lab is a place. It's not a place, does not have walls, and exists only in the talents of the partners, only in the talents of the people working there. And our laboratory is actually nothing more than a workflow. The lab is no longer a place. It is to a large degree virtual and a fluid entity. So digital technology affects definitely our profession. As a dental laboratory, you can do an optical scan. So instead of preparing a tooth conventionally with your hands, you're now doing it on a computer. You can just design a crown, and you can look at the occlusal surface, and of course, you can take this data set and finally mill it with a CAD/CAM machine. If you want to look at the occlusion, you can just use a virtual articulator, check it from all of the dimensions, and make sure that you get the right restoration. The virtual articulator today, in my opinion, is not perfect, but it's on its way. Custom milled abutments. We have heard it in the introduction before from Dentsply Friedland that we have computer milled abutments available today. So you can do an abutment which meets the individual criteria of each patient. So you have great support of the soft tissue, you have perfect aesthetic outcomes with the help of these custom milled abutments. And you can even choose between different materials. So the way that works, for example, with the company here, Compartis, for example, is you do an impression, it is scanned finally. In an optical scanner, you transfer all of these data into the computer, you design your abutment on the computer, and you can take this data set, extract it, and send it to a milling machine. There are different materials available. You have composite materials, you have metal, titanium abutments, for example, and you do have zircon available. And of course, different color shades as well. Here you can see how it works. You just choose, you set the margins here, you design the abutment, and finally, you check the crown, and all of these data sets can be extracted and sent to a milling machine. So all of this dental lab process today is really virtual. So everything what we have been doing with our hands in the old days can today be done in the computer. And that is a final restoration produced based on computer data. The dental technician is milling them, he's sending the crowns to the patient, and he's placing them in the mouth of the patient. So why are custom abutments important? Why do we love to use them? Because they really meet the individual needs of the patient. If you can look at this young lady here, she's about 21 years old. She has genetically missing lateral incisors here, very soft, very delicate soft tissue, and we're just placing an ankylosing implant here without any bone augmentation, without any soft tissue augmentation, just straight away. And I would not do a crestal incision today. This was in the older days, so I learned. But still, even with that type of incision, it works out. So we are placing a standard abutment immediately after surgery. The temporary abutments have not been available at this time. So we do immediate loading of the implant with the provisional crown, which helps you to contour the soft tissue. And that is a result after 5 weeks of healing. So the soft tissue has healed, but it's not really looking great. So that's not the result you want to have. If you look at the presentation before from the Brazilian guys, you definitely have to improve that result. We have a gray shadow here from the soft tissue, which we don't really like. So after 5 weeks, we take the abutment out. The dental technician is working on the cast. He's choosing customized abutments here with a 50-degree angulation made from zircon material. We're producing zircon crowns. And finally, these are the zircon abutments in the mouth of the patient after 6 weeks. So after 6 weeks of immediate loading, the patient gets the final restoration. What you can see here is that the soft tissue is still not great, but wait another 6 weeks to 2 months. We're doing nothing, we only wait. And after this time frame, you get a very nice, should go on, yep, you get a very nice presentation here. That is with the crown after 3 months. This patient has been treated 7 years ago, and the results are completely stable. So if you have customized abutments, if you have advanced materials like zircon, you can really meet individual patients' demands. And I love this material, I love the procedure. That is the way you can use Compartis ESOs, for example, to do removable restorations or bar restorations. Just the same procedure. You have a model, you just do an optical impression, then you send the impression to the company. They are building up the bar here on the computer. They virtually extract it. They mill it finally. They send this bar back to the dental technician, and the dental technician can work out the final procedures. So we know today from many publications, for example, this one here from 2010, that CAD/CAM frameworks, this one was based on implants in the study, were significantly more accurate than cast frameworks made with a lost wax technique. So CAD/CAM is definitely an approved technique, and there's no question about that. Here are some restorations made with CAD/CAM. 4 ankylosing implants are placed. On top of these ankylosing implants, we are placing standard abutments. On these standard abutments, we are doing galvano copings, and these galvano copings are then glued in the mouth of the patient into a zircon framework, and the dental technician is producing the removable prosthesis on top of this zircon framework. So what you can see here is some fancy attachment with a ruby in it, and it works pretty well. Another restoration, again, a zircon framework. We put a galvano coping on the framework. The galvano framework is then glued into another superstructure, which is implemented in the prosthesis, and finally you get a happy patient with a really nice, stable, and high-end restoration. Imaging technology, and especially CBCT technology, is in my opinion, one of the most important parts about digital technology. With the CBCT, and you've seen some amazing pictures already today, you can really do three-dimensional diagnostics in the way we could never have done it before except with the CT. So with the CBCT, it does influence, for example, surgical treatment heavily. If you only look at these cases, this guy had a sports injury, so there's a lot of bone missing here. You just print a stereolithographic model, and you just adapt your distractor on the model. So everything is prepared before you go to surgery. You're ready. So everything really fits. You go there, you just use the pieces and parts, and you massively reduces your surgery time, your chair time. So that's a really big advantage, and of course, finally, you really get what you really know what you get. If you look at this lady, this was not really successful implant treatment, so she lost a lot of bone around here. You can see that. So before we went to the surgery room, everything was prepared. So a titanium mesh was prepared again on a model which has been printed out of the CBCT dataset, and we go to surgery, and everything fits. You just click it into the patient's bone, and that is it. So you're pretty fast, and you're very well prepared. Or look at this young person. That's a 19-year-old person with an ameloblastoma, and you can very precisely see the dimension of the ameloblastoma, compare it to the X-ray here. So you can see it in every dimension, you can prepare every piece and part, and finally you go to the surgery room, and you finally just adapt this case. And thank you very much for Dr. Gary Ordentlicher, who has done these cases and who has presented these pictures. So we know from another publication here, Clinical Oral Investigation from 2008, that a CBCT or a CT will give a better basis both for preoperative risk elevation and the decision whether to operate or follow up. And furthermore, the surgical procedure is considerably facilitated by the knowledge of the exact anatomical relationship, thus minimizing intraoperative complications. And just an example, wisdom tooth removal, which is a standard procedure. Is CBCT really giving you an advantage? Most of the people say no, because it is not influenced the way you do surgery. You just have to remove their tooth. There's a very nice publication out there in the British Dental Journal now. They have done about 1,000 cases, and the outcome is 26% reduction in chair time by using CBCT. So it does influence nearly every surgical procedure. I'm not saying that we need CBCT in every case, but it really is an advantage. Of course, CBCT and implants are a story for itself. After you place an implant, you will be pretty sure about the location of this implant. If you look at the X-ray, it's not really clear. If you look at the CBCT, you know that the implant is not touching the nerve channel, and you can be sure that this patient will be fine. But even more important, of course, is the preoperative implant planning procedure, so you can exactly plan the implant location. You can transfer all of these data finally into a drill guide, and you can treat the patient according to your treatment plan. All of this is based on CBCT. All of your drill guide treatment is based on CBCT. But if you look at a study here, which is a very nice literature review from Snyder et al., Clinical Oral Implants Research 2009, we see that data based on CBCT still have problems. So primary bone augmentation necessary even with having a CBCT, 20%. Unexpected bone dehiscence, 7.5%. Insertion of wider implants than planned, 5%. So we really have to have a closer look at the accuracy of CBCT scanners. How accurate is that procedure really? And we did a study at the University of Bonn, where I was working before being part of the Stony Brook team. And you can see the Morita 3D scanner here, Morita Aquitomo. And you can see that this is a scan of the human mandible. You can see on the left side, this is a human mandible. And the original distance here is 30.8 millimeter. The CBCT is measuring 30.2. So that is pretty good. You have a 0.6 difference, which is okay. But if you look at the measurement of a fiducial marker, and this is a fiducial marker necessary for the Sirona drill guide system, it is a glass ball, then suddenly you have a difference of up to 1.3 millimeters. So if your guided surgery is based on a 1.3 millimeter mistake, then you don't really need it. It's not what we want. But is the Morita a really bad machine? No, it is not. The Morita obviously has problems with contrast. Because if you look here in an axial view where the glass ball is completely embedded in composite, then you can see that you measure suddenly 2.8 millimeters. So only a 0.16 millimeter difference, which is a completely different story. So if you do use a Morita scanner, you must know this machine seems to have problems with contrast detection. If we look at the Planmeca scanner, this one is pretty precise. So the difference here is only 0.2 millimeter. And if we look at the glass ball, it is able to display the really 3 millimeter. But if you look at the image quality, it is not as good as the Morita. So image quality with the Planmeca is not as good, definitely. The next machine, Sirona Galileos. Very nice measurement here. Again, 0.2 millimeter difference, very good. But the Sirona machine is the only device which is using an optical magnifier. If this tool is not really well calibrated, then you suddenly don't have a cylinder here, but a deviation of about 2 millimeters on a 5 centimeter distance. So again, every CBCT scanner seems to have its very own characteristic, and you must know the device you use. Look at this scanner. This is the Vatex scanner. If you look at this scanner, you can see here that our first measurement was here, but the real 3 millimeter is here. So you have to exactly know your machine, and that is pretty much important. If you look at the image quality of different CBCTs, you can see that there are huge differences between all of these scanners. So the 3M Imtech scanner, you can see here, has a very precise measurement, but the image quality is not really crisp in comparison to the other scanners. This image quality of the Planmeca is not really great. Oh, this one is a little bit offset. So that was probably at 4:15 this morning. And this one, the image quality is good, but the contrast is a problem. And now look at the artifacts. Very good is the 3M Imtech machine, nearly no artifacts, and the Planmeca and the Morita scanner, completely different. They are really struggling with the artifacts. And now, this is a glass ball, which is really nice. But what are implant planning systems which are lab-based really use? For example, the Straumann system, they are using metal markers, which have a diameter of 0.2. And if you look at these scans from the Planmeca CBCT, you now see where we are going to. So that is a measurement of 0.43, which is, by the way, but this is, centimeter. So you have a deviation of 0.2. which is a definite disaster, because these fiducial markers are used for the registration process of the whole guided surgery system. So all of your registration will be offset, meaning all of your implant position will be offset. So Dentsply Materials is using a system without these fiducial markers. They don't depend on these, so they don't have that problem. But all of the other systems working with fiducial markers are definitely having a problem with the registration procedure. And if you're using a CBCT scanner, make sure that the detection of the fiducial markers you're using in your dental office is correctly done by this CBCT. And if you now look at the results of this study, it is not amazing that you can see that it's pretty accurate regarding the anatomical detection. So average error only 0.13 millimeter. But for the glass balls, not for the metal markers, only for the glass balls, you get an average error of 0.44 millimeter with a maximum of 1.4. So CBCT is a great technology, and I really like it a lot, but still, it is not perfect today. I just published with Gary Ornlicher together a chapter in this book, and my personal opinion is that the advantage of CBCT is really that a new technology based on 3D evaluation of patients for dental implants has opened new avenue for clinicians for treatment. And that's what it's really about. So I really like the technology, and I hope that it will get better and better every single generation of these machines. So to improve the accuracy of CBCT, we can attach it to an optical scanner. Because optical scanners are really very accurate, and if we match these two data sets, you get a very precise basis to work on. Of course, you can't do that for implant treatment, so you can just start planning an implant, and you can plan the dental restoration, the prosthetic restoration on the optical scan. I'm not even mentioning that. I know that you all know that. But it's also influencing completely different kind of treatments, like for example, the Invisalign treatment. Orthodontic treatments working with retainers. They are mostly set up today working on optical scanners. So you're not taking into consideration all of the root surfaces. You don't really know how long you need to move that root. You have no idea about the bone density. So we're using that treatment a lot at University of Bonn, and we have up to 50% relining, meaning we need a second set of retainers after the first one. So if you can take into consideration not only the occlusal surface and the crown, but also the root surface, that would definitely enhance this kind of treatment. And with CBCT, all of that is possible. So we have a CBCT data set here, and you can just segment a single tooth. That is pretty easy to do. And after the segmenting of this tooth, you do have a data set here showing you the tooth in its original position, and you can finally look at it from every single angle. Then the orthodontist is going to the computer and looking at the perfect position, so the position he would like to have that tooth on after treatment. And finally, you can just go step for step and produce the retainer, and step for step move that position in the right or final position of that tooth, and you can transfer all of these data into a final retainer. So digital technology is not only for implants, it's really affecting every profession. I really like this treatment. This treatment has been introduced by Dr. Yangopol to my university in Bonn, and it's a really sophisticated approach. What you can see here is a trauma case. So this guy had a trauma. You can see the original implant, the original X-ray here, and this tooth is extracted after trauma. After that, we are cutting off the root. You can see that on the pictures. We have standardized equipment. The root channel is drilled from the apical. That is the only time that I can do an endo. And finally, this is the result. So then you put cement into the root here, and you place a machined titanium pin. After that, the young guy is sitting on a chair watching television because you do the complete treatment out of the mouth, which is really great. You're not bothering the patient at all. So this is one of the very few treatments where they really like you. And we just provide a titanium retainer. We replace the tooth and stabilize it with a retainer. It's a very simple procedure, really simple. And that is the case how it looks like immediately after treatment, and that is the way it looks like after healing. And if you look at these x-rays here, for example, you can see that this x-ray here, look at the bone level, and look at the bone level here. After healing, you're not losing hard and soft tissue. So this treatment is really working, very predictable, and I'm very happy that I got the chance to learn this kind of treatment at the University of Bonn. I really love it. And how is digital technology influencing that? You can see it here. I have a three-dimensional data set. I segment the tooth. I cut it off. I know all of that before I go to the surgery room because I'm producing a reduction guide. So that is my tooth. I know exactly how I have to cut it here. And what you can see here is that the guide is covering parts of the crown as well. Why? Because there are some cases where you do not only have to cut off the root and cement the titanium pin, but where you also have to cut off the crown. In this case, we have transplanted, it's not a replantation now, it's a transplantation. We've transplanted this milk tooth into this position here, and we cut off the complete crown, and we have to redesign it with composite. And we have seen before, and next time I would love to invite the Brazilian artist to do that, because you show really amazing work with composite. So you just stabilize it for 2 to 4 weeks. After that, look at the x-ray here. You have a big gap between the bone and the tooth, and after healing, no bone loss. There's a complete periodontal reattachment, and this child can have that tooth for another 10 years. You can even do the orthodontic treatment. You can do whatever you want. So he doesn't have to wear a flipper. He's not compromised in his social life. And by the way, if you do have an implant with a very thin facial plate and you know that after extraction you will lose all of that bone, take out the tooth, prepare it in this way, replant it, and you can be sure that you will not be losing the bone. After that, take it out, place an implant, and you're just fine. So it's also a kind of pre-implant preservative measure for bone and soft tissue. Wow. That was loud. So everybody's awake now? That's pretty good. I know that Stuart Gans is going to talk about guided surgery in lengths, so I only want to touch that topic because it is an integrated part of digital technology. And you can see that not only the surgeon can do all of the digital planning, but also the prosthodontist can do full-size planning. You can see the implant position here from every angulation. You can look at the abutment, and you can see and finally transfer all of that to the patient with the drill guide, and this is guided surgery with the expertise system. So if you look at this case, 6 implants are placed here. The final planning, they're transferred. You can prefer before surgery. You can prepare temporary restoration. You go to the surgery room. You place your implants. We have galvano copings, which are placed in the restoration passively in the mouth of the patient. You just glue them in. And finally, the restoration is placed. So all of this needs only 1 hour, 20 minutes, very fast, very predictable procedure. I definitely don't know how you would do that without digital technology. And after 3 months, we are coming back, we are placing customized abutments, and we are placing the final restoration. So if I would have a wish regarding digital dentistry at the very end, all of this, what you see here, are island solutions, working in isolation rather than in an integrated fashion. And I would love to have one platform which integrates all of these technologies for the benefit of the patient and the dentist. Thank you very much for your attention. It was a pleasure being here.